Hello, good morning, everyone. Thank you, Catherine, for the introduction, and thank you, Katie, for inviting me to come and speak about this very important piece of work that we started, and we still have a lot to work on in the next few months and years to improve the care for our Black, Asian, and minority ethnic women, as well as all women in the BHRUT. Yes, so I'm just gonna, so my name is Maria Benedetti. I've been a midwife here at Queen's Hospital for the past 5 years, and I started here as a student in 2013. So it's very excited to be part of this work that we're doing. And today I'm just gonna speak a little bit, just give you a glimpse of some of the work that we have been doing from last year to help to improve the experiences of Black, Asian, and minority ethnic women residing within BHRUT. Yeah, do you mind going for the next slide, Katie? So I'm just going to start. The NHS long-term plan is a national ambition to reduce the rates of maternal deaths, stillbirths, and neonatal deaths and serious brain injury by 2025, to reduce that by 50%. And this will be achieved, one of the ways this will be achieved is through the Better Births vision to make childbirth journey a lot more personalized, kinder, safer, and more family friendly. This is what the women said they wanted when they did the review in 2016. And this will be delivered across the local maternity systems through various work streams. There's 10 work streams at the moment. So one of the ambitions is to have 75% of Black, Asian, and minority ethnic women receiving continuity of care by 2024. It is a huge ambition, but I believe with a lot of work, we can get at least very, very close to it with us working all together and going towards that same direction. Next slide, please. So health inequalities faced by Black, Asian, minority ethnic women, I'm sure is something that we are all very much aware of, not only for the women, but just across the board for Black, Asian, minority ethnic people in general. So currently in the UK, up to last year, Black women were 5 times more likely to die. So there's a great disparity there. And with the latest report from the Embrace, which is a report that is done every few years to check how many maternal deaths we've had, how many neonatal deaths, how many stillbirths. So they check that, they gather all the data, and that informs us on the current state for us here in the UK. So at the moment, Black women still 4 times more likely to die, unfortunately, from complications related to pregnancy in comparison to their white counterpart. And Asian women are twice more likely to die and to have complication. And women of mixed background, they're 3 times more likely to have these complications. So we have a lot there to work. This is not a new statistics. This has been there for many, many years. I think it's only from last year that we really started to get magnifying glass and hearing the voices of those unrepresented groups to really start doing some work nationally and locally to do some work about this to improve the outcomes. Black women represent 4% of the birthing population, yet they are overrepresented in the maternal deaths. So we've got a lot of work to do there to look into this. So during the first wave of COVID-19, this was exacerbated even further, because it showed that 55% of women admitted to hospital with COVID-19 were from a Black, Asian, or minority ethnic group. This is on a study that was done between March and April of 2020. And also Black women were 8 times more likely to require a hospital admission if they were infected with COVID. And these were women that already had predisposing conditions like diabetes, heart problems, and situations that would make them a higher risk. So nationally, this was just a huge importance to look at how can we reach out to these women with targeted communications, to reach out to them and see how we can help to improve the experience, especially during a time where face-to-face contact with the midwife was a lot less, and to give them advice about vitamin D. Also, one thing that was highlighted is the lack of consistency, recording the ethnicity of these women at booking. So that's a bit of work that we did last year to try and improve that. I'll tell you a little bit more about later. Can you please go to the next slide, Katie? So our response, BHRUT, I'm very pleased to say that although a lot of this was a lot more highlighted during the pandemic, we already kind of ahead of time, because this role, there was a role that was created as an opportunity as a secondment end of 2019. And I had the privilege to be one of the first midwives in the country to step into such a role, the first of its kind prior to COVID. So this role was created as a response to the 5 times more, statistics of Black women dying in the UK. And so this role was created actually to go in within our community teams, the areas of, to see, for example, what are the needs, what are the disadvantages that our women are facing, what were some of the barriers that they had in terms of accessing care within BHRUT. So that meant that between January and March 2020, I was assigned to go to the community teams residing in the most deprived areas of BHRUT. Those areas were Dagenham, Ilford, Havering, the Ilford teams, and also Goodmayes. It was a very interesting journey going. Some of the things I used to do is sit just at normal appointments, build rapport with women, kind of listen to see how do we engage in our services, seeing what services are we offering, trying to identify any gaps that could be a barrier for women coming into our services, and also hearing from the midwives as well, providing the care. One of the things that was amazing to see is how excellent services we have, how excellent our midwives are at providing the care, and really being responsive to the women, because sometimes we do focus a lot more on the negative feedback, and the good feedback sometimes is not always shared as widely. So going to hear that directly from the midwives was really, really exciting. So before I go further into that, I just want to say the title initially was started as BAME Specialist Midwife. This was a title that initially I didn't feel very comfortable with, because one of the things, or one of the feedback women have been sharing, hearing a lot from last year especially, is women going away from this term using BAME, because all women are grouped together in one group, and sometimes the Black women might have their own issues they're dealing with, Asian women and the other ethnic minority groups. So it's very important to try and find a new terminology to use. This might still not be the best one, but hopefully moving forward, we can have a term that we can all use that's not offensive to anyone, and actually address the needs of all women that need to be represented. So this title was then changed to Multi-Ethnic Empowerment Midwife from June last year, and that's what's been known since. So one of the things I did was collect feedback from women, have conversations with them where I would ask them a lot of questions. Women that had babies with us prior to the current pregnancy they had at the time, so they had history with us already. It was important to know what was the journey, what was the experience, what were the good things, what were the things that we needed to improve as a trust. And also, one of the things especially I was telling them is it's very important to hear experiences, not only the negative, but also the positive. And your feedback is really important to help us shape future services. Women engage very, very well, and they shared loads of feedback. Initially, it was around 95 women that I spoke to, but in here, of course, 75, feedback from 75%, for 75 women, sorry, and the feedback is represented here. Some of the common themes in the positive feedback was things like they felt treated with respect and dignity from midwives, from doctors, from everyone really that was part of their journey during pregnancy. Other things was they were really happy to see the same midwife again during the pregnancy. Some of the things they said was really good to be able to see the same midwife and not having to repeat their stories over and over again. Some women, it was even good to hear that in the previous pregnancy, they had their similar midwife, and then they were able to see the same midwife again with their second and third pregnancies, because they were a part of the same team. Because this supports also the vision of continuity of care. This is some of the things that women are really saying that they want to have. Also, a lot of women shared good experiences of having support during breastfeeding, whether that was their first baby or second or third baby. This was very, very good. I also shared here some of the common themes in the negative feedback. This is also very important just to help us understand what kind of things do we need to work on as a trust. And also, it was very interesting to see how it was very similar to what women were saying nationally from other meetings attended, and also sharing with other hospitals as well. Some of the things they did say is that they did not feel listened to when they raised a concern, either to a midwife or to a doctor. Other was like they felt nervous about coming to Queen. That was due to negative feedback from what happened years ago, or family members or friends that had, for example, a negative experience, which again correlates to where we used to be. Queen's Maternity, we've been very open about some of the challenges that we face, especially when the hospital first opened. So this was about now us, how can we build the trust of these women again? So this will be a place where they would choose to give birth, and also to share that also with their family and friends. Some of them said they felt treated more like a number rather than an individual. on the postnatal ward. I thought that was quite interesting because these women, what they were saying is that during pregnancy, a fantastic experience, during the interpartum period, a fantastic experience, but then once they reached the postnatal ward, they said they felt their midwife sometimes would not always have time to give them that breastfeeding support and just to be there, because it was a huge change from what they had had before. And also the last one is that they really felt a little bit let down, but it was not the percentage of those women they gave just negative feedback was 2% from the women that I spoke to. 53% shared a positive feedback, and 45 was mixed feedback, where it was something very good and something that could have been better. Next slide, please. So some of the improvements that we did, and the original plan was to, when I went to the 11 weeks to the community between January and March, came back where I had to scope resources and also make recommendations on service improvement moving forward. The day I arrived with the report, that was also the day that COVID hit, the first wave, and we needed to stop a lot of the services in the community. So from then on, there was a break of like 3 months with this report, just waiting for the best time to restart it again. Was everyone hands on deck and providing the support in the unit. So from June 2021, then a specific plan was developed with consultant midwives for normality and also for, the name is just gone. So both consultant midwives and also with the head of midwifery, we sat down and we made a plan. How can we, respond to the pressures of COVID? How can we reach out to these women? And based on also some of the findings from the initial work that was done. So one of the things that came out of that, the action plan, there was very specific actions. One of them was to pilot a caseload of phone support to women with high risk pregnancies, and to kind of just give us an additional support to what they were getting from their community midwife. This involved just every couple of weeks, just giving them a call, finding out how they were getting on, finding out if there's any specific issues they were experiencing, any support, and also an opportunity for health promotion to talk about vitamin D, to, just to reiterate to them the importance of contacting the 24-hour maternity helpline and contacting their midwife if they were to face any concerns during that time. I would say that 70% of these women engaged meaningfully, meaning that they were in regular contact and they were able to be signposted to extra services. And this reported that it was actually very, very good, and they felt that it was good for someone to reach out to them outside of the meetings or the appointments that they had with their midwife. Another thing that we put in place was a pilot of a virtual support group for Black, Asian and minority ethnic women. This was actually very good. It was a little bit slow at start because it was a virtual group, and being very mindful that it would not probably be the best for all women, especially women with a language barrier. This was not something to fix, something for everyone, but it's a support that was there. 13 women engaged meaningfully during that period of September to December, and they reported finding the service really beneficial. During the support group, they would come and just kind of share their experiences of how they were feeling at the time, have opportunity to hear from 1 or 2 women that were in that same session, and also to kind of receive support, ask questions about the constant changes that were happening, and also to kind of give us opportunity to learn from different cultural backgrounds as well. Yeah, so this was really, really good, and hopefully something that we can implement again in the future. Next slide, please. So what else has improved? So one of the findings during that first 11 weeks in the community is that information was not always available in a format that would be, accessible to all women, especially women that English was not their first language. So this was then changed in ways that we still have a lot of work to do. And now our website, our Queen's website, we now have information available in various different languages and available to women. For example, if they go to an appointment, the midwives can either signpost it to them or actually print it to them for them to have access to this information. During the COVID-19, the beginning of it, especially where it was highlighted that Black and Asian women were a lot more, at risk. So there was a video that was put up on our website, and there was information that was specific to them. And we still have a bit of work to be done there, but hopefully we'll get there in the end. The improved data collection on ethnicity. was also a problem that was identified. But a lot of work was done to the point where even midwives, for example, was able to see which teams, for example, were not recording that data, because we have the two systems. We have the E3 and the Medway, so we're able to pick up if the information was not entered, for example, in one of the systems, or Medway would not feed into E3. So that was quickly changed, and within a couple of months, we're only missing maybe about 10, when before we're missing about 200 before of that information. One of the things that we started doing was having some unconscious bias conversations / training with staff. We had a couple of sessions. This was done with our PMA, with our midwifery advocate, and just to have conversations with staff, especially during the time where a lot of conversations was coming up about racism, about unconscious bias, especially about on the back of what happened with George Floyd last year, is about actually helping us to understand how our biases can affect the care that women are receiving, because this is also something that they were saying. Women are saying they didn't feel listened to, they didn't feel treated the same. So it's very important for us to see what is it that we need to change individually to help us identify our own biases. So also what's been also changed, which is fantastic, we have access to the cultural competence training on the e-learning for healthcare. This is now made available on BEST, so that all staff can access this. So all healthcare professionals can access this training and just, inform themselves and actually help them to improve, because when we're providing care, we need to be able to understand all the cultures that we are, serving in this area. So this is something that midwives can access to as well. So in the collaboration with the Maternity Voices Partnership, we now are able to kind of reach out to women from these underrepresented groups, to also to plan services around them, to kind of get women and their families involved in how is it their experience was, negative or positive, and then they can help us then to shape services that will wrap around them and suits their needs. The permanent post for the multi-ethnic empowerment midwife is now in place, I'm very pleased to say, because initially it was started as a secondment, but from June, I believe this year, there's a new person now taking on that role and doing some fantastic work to continue to identify and really put measures in place to address, the needs of our Black, Asian, minority ethnic women. Next slide, please. So plans moving forward is, again, I've mentioned before, regularly evaluating the feedback of Black, Asian, and minority ethnic women. This will be done in collaboration with our Maternity Voices Partnership. We're also going to be working across our LMS and learn from them and share learning and to help improve our services. We'll be working on the development of personalized care plans to make sure that it suits the needs of all our women, because the plan is that all women will be receiving continuity of care moving forward, although we have this drive to make sure that 75% of those women are from a Black, Asian, minority ethnic background. We're going to do a lot of work there, making sure that we have a personalized care plan, which they can write in, which their voices can be heard and can help us to understand how we can meet their needs in a cultural way. Recently, there was some data, for the first time, some data was shared on our actual, what is it actually, does it look like? What is the outcomes for our Black, Asian, minority ethnic women? And hopefully in future that can be shared also across to everyone to see that actually our own data matches the national data. It's not just something that we're hearing out there. Our women here in EHRUT, we need to put a lot of attention to help to improve their outcomes, so that maternal deaths, stillbirths, and also for neonatal deaths as well. So also moving forward, there will be a huge drive in setting up continuity of care for Black, Asian, minority ethnic women residing in our areas of high deprivation. At the moment, it's a little bit of a challenge because of staffing issues, but hopefully moving forward in 2022, this is something that can be really put in place to address the needs of these women, and also to continue, across the board, having training for staff on unconscious bias, on racism, and on microaggressions. Very uncomfortable topics that a lot of people might find hard to address, but it's really, really important and vital, because this is something that we can all have a part to play in case if that is one of the factors. There's many factors that could be causing this. So yeah, next page, please. Yeah, well, that's it. Any questions?